I'm going to talk about role of GLP-1 and GIP agonist in cardiovascular health. Diabetes and cardiovascular diseases are considered to be almost the same thing. Diabetes is cardiovascular disease risk equivalent, and patients who are diabetic should be taken care as if the patient is having coronary artery disease. So there are some drugs which were developed to be antihypertensive, anti-diabetic, but they were found to be more beneficial in cardiovascular health. So GIP and GLP, they are incretin proteins. They are created by the GLP is created by the L cells in colon and distal ileum, and GIP is secreted by the duodenum and jejunum by K cells. They have variable effects. Upon food ingestion, the gut releases these incretin proteins, and they inactivate the GLP and GIP are inactivated by DPP-4 inhibitors. They are glucose-dependent hormones. Both they increase insulin secretion by beta cells of the pancreas and increase glucose uptake by muscles. They decrease production of glucagon from the alpha cells of pancreas and decrease hepatic glucose production by liver. So they have so many effects almost on so many systems. On stomach, this decrease gastric emptying and decrease acid secretion. On gut, this reduces motility and lipoprotein secretions. In adipose tissues, increase lipolysis. They act on the liver to decrease glucose production and decrease steatosis. They act on the kidneys, which we will discuss, on muscles and heart, which we will discuss. And in brain, they decrease food intake and increase satiety. It is a congested slide by biochemistry, complex biochemistry, but to cut it short, these incretin proteins reduce production of reactive oxygen species, decrease inflammation. They reduce activation of monocytes and macrophages, and the foam cell formations and atheroma is reduced. They reduce apoptosis of foam cells and thus prevent destabilization of the plaque, and they prevent rupture of the plaque, which leads to acute coronary events. So the extra pancreatic effects, at the end, they reduce insulin resistance, they decrease body weight, they decrease blood pressure, decrease blood lipid levels, and decrease blood glucose levels because of so many mechanisms. On kidney, they prevent new onset macroalbuminuria. And macroalbuminuria leads to cardiovascular and cerebrovascular complications. They reduce urinary albumin secretions. They slow the decline in eGFR. So many trials are underway and have completed from 2015 and are ongoing. The leader trials, Excel trial, Rewind trial, and Surpass cardiovascular outcome trials. I'm not going to the details of all trials, but the leader trial, which was on Victoza, liraglutide, it was a randomized trial where more than 9,000 cases were enrolled of type 2 diabetes. They were followed for 3.5 to 5 years, and it was found that they reduced MACE by 13% versus placebo, and they reduced cardiovascular deaths by 22%. They showed benefit in kidney function and weight loss. Sustained trial series was done on semaglutide, and Sustain 6 was done on cardiovascular outcomes of semaglutide. They enrolled more than 3,000 patients of type 2 diabetes who were at high risk for cardiovascular complications. Median follow-up was 2.1 years. They significantly reduced MACE by 26% compared to placebo, and reduced the incidence of new or worsening nephropathy, but the higher the rate of diabetic retinopathy was found. And the SURPASS trial is on dual GLP and GIP agonist. It is expected, this is underway, but it is expected that it will lead to more benefits from cardiovascular point of view. This is a randomized, this was a systemic review of meta-analysis of 12 randomized controlled trials. It was the trials which were published between 2016 to 2024, and they concluded the GLP-1 receptor agonist improved kidney and cardiovascular outcomes and survival in patients with CKD enrolled in any array of clinical trials. This was published in May 25 in American Journal of Kidney Diseases. The cardiovascular complications are the main causes of morbidity and mortality in diabetic patients. There is two-thirds of diabetic patients die of causes attributable to heart. There is 2.5% higher risk of developing congestive heart failure in diabetics. 1/3 of diabetics usually develop peripheral arterial disease about the age of 50. And there is 4-fold increase in the incidence of stroke for each 1% increase in HbA1c. So what are the guidelines? 2023 ACHA guidelines for the management of patients with chronic coronary artery disease. They recommended that in patients with CKD, with CCD, chronic coronary disease, who have type 2 diabetes, the use of either SGLT2 inhibitor or GLP-1 receptor agonist with proven cardiovascular benefits is recommended to reduce risk of MACE. And the cost value of statement of GLP-1 is better than SGLT2. And regarding weight management in patients with chronic coronary artery disease, of course, we have to observe lifestyle modifications and other measures. But for patients with CCD and overweight or obesity who have pharmacological therapy is warranted for further weight reduction, GLP-1 receptor agonist can be beneficial in addition to counseling for diet and physical activity, as it is reasonable to choose semaglutide over liraglutide. So semaglutide was found more beneficial regarding weight reduction. So if a patient to reduce cardiovascular risk independent of glucose control in patients with type 2 diabetes and ASCVD, GLP-1 receptor agonist is class 1 indication, SGLT2 is class 1 indication, and after these medications we have to think of metformin and pioglitazone. And under to European guidelines on diabetes in patients with ASCVD, liraglutide, semaglutide, and dulaglutide are recommended in patients with type 2 diabetes to reduce cardiovascular events. But they have neutral effect on the incidence of cardiac failure. GLP-1 receptor is recommended at a GFR if they are friendly in kidneys. So if the GFR is more than 15, they can easily be used because they reduce progression of renal dysfunction. The side effects of these drugs are very low. Nausea, which is a side effect of almost every drug, nausea and vomiting. Nausea are noted in 25% of the patients, but these are usually self-limiting. Acute pancreatitis and medullary thyroid cancers are reported with these drugs. So the side contraindications are history of pancreatitis, history of medullary thyroid carcinoma, and diabetic retinopathy. So in conclusion, GLP agonists have proven cardiovascular benefits. They reduce MACE and cardiovascular deaths. Dual GLP-1 and GIP agonists may offer additional advantages. The trials are underway, and they have the potential to revolutionize cardiovascular management and metabolic diseases.